What are the rationalizations then? You're giving this to me, actually. For the early initiation of LAIs, you ramp up and go, as opposed to waiting till the cows come home.
Yeah, because I think, if we know that half of our patients are going to have trouble taking medicine. There was a very seminal study that was published out of a national registry database in Finland, where 2,500 first episode schizophrenia patients were followed. And within 60 days of discharge from the hospital, within 60 days, half of them were not taking their medicine.
Half?
Half.
In Finland?
In Finland.
Okay. Where people, I suspect, have their databases followed and people are very adherent. This is, America's the Wild West by comparison.
Well, it shows that even people in Finland are not so adherent.
Apparently not.
I think it's a worldwide problem. I think it's, as I said, it's human nature. People don't want to take medicine for many different reasons. So if we assume that half of our patients are going to have trouble taking their medicine, then why not offer the long-acting formulation to everyone? And say that this is the way we treat your illness. And I think the problem is that many clinicians will wait until 2 years, 3 years, 4 years down the road after someone's had multiple hospitalizations, and then they say, oh, well, gee, why don't we try a long-acting formulation?
Let's turn this upside down. It isn't the patient that's the problem.
Right.
It's the physician and the assumptions inherent in most physicians that they're doing it right and their patients are better and their patients are adherent, all of which we know is poppycock. No?
I think so. I mean, I'm sure there are some patients out there who are very adherent, but it's hard to identify them. And I think if the long-acting formulations had more side effects or there was some reason not to use them, I could understand that. But there really is no evidence that they have more side effects. In fact, I believe that if you can use a lower dose often with the long-acting formulation because you know exactly how much medicine the patient is getting.
Got it.
And sometimes that will result in fewer side effects.
So there's no missed doses, so you don't have to give enough to counter the odd day when
That's right. And you don't have a patient who decides, okay, I'm going to skip my medicine over the weekend, and then I'm going to double the dose on Monday, and then you come in with a side effect that you're like, hey, what's going on here?
Right. Is there a way, short of these long-awaited and often outdated guidelines, to encourage the clinicians to initiate injectables and long-acting injectables earlier?
Yeah, well, I think that's something that we're very interested in is how do you incentivize people to do this? I think this applies across all of medicine, right? How do we get those new findings implemented into clinical practice more quickly? Some of it's training, some of it may be also access and payers, and the payers could be doing more, I think, to provide incentives, because one of the arguments that we hear from clinicians is that, well, it's a hassle to do this. I have to find someone to give the injection. It has to be, some cases it has to be refrigerated. In some cases,
what?
Exactly.
We do this for lots of diseases.
That's right. That's right. So I think that the hassle factor is not a good excuse.
No.
But if it does take more time, maybe there needs to be some additional reimbursement for that.
What about an institutional protocol? Does your institution have one that encourages LAIs?
We encourage it. We don't have a protocol per se that says you must do this, but we definitely encourage it, and we have lots of in-service training about the use of long-acting injectables. We have a special clinic that provides injections where we have nurses available to give injections to the patient, so it makes it very convenient, very easy.
I know we've discussed the way you approach a patient who may or may not be needle shy, for lack of a better phrase, to accept this therapy.